Hello friends. Now before you go to this image or before you go to this question itself, just look at the long list of examinations in which this particular diagnosis was asked. It is probably the condition which has been most frequently asked in your exams. And there's a reason behind it. Your examiners are asking you these questions on perforation, pneumoperitoneum, obstructions, fast, right, recently. That is what we're going to study in this video. Is because these are very, very critical diagnoses and your examiner expects you to know and make these diagnoses on these basic investigations. The sad side is that if you miss this diagnosis, by mistake, the patient may miss his chance to live his life after this, because even a couple of hours of delay in the management of these patients can send the patients into sepsis, and therefore this is really a critical time bound diagnosis, right? So what is this patient present with? Patient presented it to the emergency department with severe abdominal pain. An erect radiograph was done. Based on the findings, what should be management? What is the finding? Look at this finding here. What you see here basically is that this is a jet black hyperlucent area just below the domes of diaphragm on both sides. So this is the fundic bubble, right? So on both sides below the dome of diaphragm you see free air, which means that the bowel is perforated, which means that this is pneumoperitoneum, and therefore the next step, what you need to do, definitive management in this particular patient, is going to be an emergency laparotomy, right? So this is what is the answer of this particular question. We'll discuss pneumoperitoneum, how to diagnose it best, earliest is what, best is what investigation. So that is something that we'll discuss. See, another question which was recently asked: patient presents with abdominal pain and distension. X-ray is done which shows dilated bowel loops as given in the image. Identify the segment involved. So this is actually intestinal obstruction, but they have not asked you, what is the diagnosis. They have pointed to a particular loop and you are supposed to look at one, the location of that loop, where is it located in the abdomen, and two, you are supposed to look at the bowel wall folds which are here, continuous transverse mucosal folds extending from one wall to the other. So these are called as what? These are called volvulae conniventis, which is a feature of small bowel. But is it jejunum or ileum, or is it the duodenum? This is something that we'll discuss in detail as we go ahead. Patient following a skid resulting in a motor traffic accident was brought to the emergency medical room 2 hours later. On examination, he was stable, conscious, pupillary response was there, but there was tenderness and bruising over the left lower chest wall, a very dangerous place to have injury. Why? Because the spleen is here. He had petechia as well. Severe tenderness was elicited in the left hypochondriac region, probably some rib fractures. He was having pain. Look at his blood pressure. Blood pressure is low. He is in hypotension. If you see a patient like this, what is the next step to be done? The next best investigation to be done in the emergency room for assessment of abdominal trauma is focused assessment with sonography in trauma, and that is called as FAST. What is the concept of FAST? What are the views of FAST? What is the standard protocol of FAST? What is extended FAST? Right? This is something that we'll discuss in this particular technique, in this particular video. Let us start now. We'll discuss everything about the FAST technique when we go to the topic. First, let us look at pneumoperitoneum. So see here, the easiest way to diagnose pneumoperitoneum is whether you're looking at a chest radiograph or an abdomen radiograph, always visualize the areas under the diaphragm. If you see here, under the diaphragm, we have seen this is a jet black hyperlucent appearance. So this actually is the fundic bubble, but you can actually see air separately, free air separately. So this is free air under both domes of diaphragm. Whether you're looking at a chest x-ray, again I'm saying, or you're looking at an abdomen x-ray, make it a point that you always look below this region, below the region of the domes of diaphragm, because as I said at the start, you just cannot afford to miss this particular diagnosis. So what is the best x-ray or best radiograph to detect minimal pneumoperitoneum? The best radiograph to detect minimal pneumoperitoneum, remember, is a x-ray chest erect radiograph. Usually what we do in our hospitals is an x-ray abdomen erect. But the overall best for detection of minimal pneumoperitoneum is an x-ray chest erect. Why so? See, because the region of interest that we are trying to look at when we want to detect pneumoperitoneum is the region below the dome of diaphragm, right? That is where the free air is. So if this is the area of the free air, when we do an x-ray erect abdomen, the horizontal x-ray beam, because the tube is centered in the central abdomen, The horizontal X-ray beam is passing through central abdomen. Is the central abdomen our region of interest? No. So the tube position is too low for the pneumoperitoneum. So it may not be seen because an oblique X-ray beam is passing here. It first passes through liver, then passes through the free air. So it may not be well depicted on the X-ray film. But what happens when we do an X-ray chest erect is that the center X-ray beam or the central beam is usually at the level of inferior borders of the scapula. This is level at the T8 vertebral level. So a more or less horizontal X-ray beam perfectly passes through this air here, and this horizontal X-ray beam therefore perfectly depicts it as a clear zone on the X-ray image, and that is the reason why an X-ray chest erect is considered to be the better radiograph, or rather the best X-ray or radiograph. But if your examiner asks you what is the best investigation, then remember a concept that we have discussed. Fluid is friend of ultrasound, right? And air is enemy of ultrasound, right? So wherever you want to detect fluid in the body, what will you do? You'll do ultrasound. But wherever you want to detect minimal amounts of air, ultrasound does not work, right? So what do we use in such cases? We use a CT scan. So CT scan is the investigation of choice, remember, for detection of minimal pneumoperitoneum, right? So lung window images are considered to be better. See, this is a lung window image because of the high contrast that they offer. You know, all this black area is nothing but free air which has risen up to the non-dependent part, right? Air will rise up to the non-dependent part just below the intra-abdominal wall. So that is how pneumoperitoneum would look like. It would appear as jet black area, free jet black area in the non-dependent part, right, in the supine position. Now, there are various signs that have been described, right? I'll come to this image, what this inset image is. But before that, remember that all these signs have been described on supine abdomen radiographs. On supine radiographs of the abdomen. Why? Because in the United Kingdom, where a standard book of radiology, which is called as Granger, is based on the Royal College of Radiology practices in the United Kingdom, and they usually do for an acute abdomen, they do an erect chest radiograph and a supine abdomen radiograph. So all these signs have been described on this in this standard book called as Granger on a supine X-ray, and therefore for your exams, it is very important that you know them. What are all these signs? See, in a supine position, you know, all the air rises up and collects just below the anterabdominal wall. When it collects just below the anterabdominal wall, it creates this oval lucency, and this is what is called as the football sign. That is because air has risen up, collected centrally below the anterabdominal wall, creating that oval lucency. This is called as football sign. Now, this free air also rises up towards the diaphragm. It goes and it lines the diaphragm from below. This creates this dome-like appearance, like the dome of a religious site, and this is therefore called as the cupola sign. This dome-like appearance, because air is lining the central tendon of diaphragm from below, is called as cupola sign. Now see here, can you see these two lines here? What is this? This is nothing but the falciform ligament. Normally it is not seen, but falciform ligament is peritoneum, peritoneal bilayer, peritoneal fold. So it is water density. When in pneumoperitoneum, it is lined by air density on its either sides. Differential radiographic density theory creates a sharp margin, and therefore we are able to see this falciform ligament as a sharp margin. That is given a name, that is called falciform ligament sign. Similarly, on an abdomen X-ray, we would never see a sharp margin of the liver or even a sharp margin of the gallbladder. But when these are also lined by free air in pneumoperitoneum, they become visible, and this is called as the GB sign or the liver edge sign. Right? Now, watch carefully. Whenever we see a bowel wall, we only see one layer of the bowel, that is the mucosal surface or layer, because air within the bowel lumen lines the bowel wall, and differential radiographic density theory creates that sharp mucosal margin. Why serosal margin is never seen? See, if this is the bowel wall, let us have a look here. See, if this is the bowel wall, right, like this is the lumen of the bowel. Now, if the lumen contains air, right, so the luminal density is air density, bowel wall density is what? Water density. What is the normal content of the peritoneal cavity? It is peritoneal fluid, which is water density. So on the outer side, serosal surface, you have water density, you will never see this margin. But on the inner side, you have water density and air density, so the inner margin may be seen, isn't it? Now, what happens in pneumoperitoneum? In pneumoperitoneum, this peritoneal fluid is replaced by air. So outside, what is there now? Air density. So see, on both sides now, there is air density on the outside. So do you realize you will see the inner margin, but now because this water density of the membrane or the bowel wall, right, bowel wall is water density, is now lined by air density on the outside. So the outer wall will also become visible. When you see both inner mucosal and outer serosal wall layers of the bowel, it is called Rigler's double wall sign. If you watch carefully here in this particular image, see, for this bowel, you are able to see the inner margin as well as the outer margin. See here also, inner margin, outer margin. See here also, inner margin as well as the outer margin is seen as a sharp margin. This is differential radiographic density theory. This is what is called as Rigler's double wall sign. Now, sometimes this air may go and get trapped within the Morrison's pouch. What is Morrison's pouch? It is the hepatorenal pouch. It is the triangular area between the liver and the right kidney. So when it gets trapped there, it creates a triangular shape like this. And this is given a name. This is called as the Doge's cap sign. So it creates a shape like this, a triangular shape like this. And this is what is called as the Doge's cap sign. So various signs have been described. So because abdomen is full of gas, the X-ray is full of signs, and pneumoperitoneum is a very important condition for your exams. You must know all these signs. So football sign, central lucency. Cupola sign, dome-like lucency created because air lines the central tendon of diaphragm. Falciform ligament seen as a sharp margin, falciform ligament sign. Liver and GB edge seen as a sharp margin, liver or GBH sign. Both bowel surfaces, mucosal as well as serosal, seen together as a sharp margin is called Rigler's double wall sign, and Doge's cap sign is the triangular shape of air trapped within the Morrison's pouch. Yes. So see here, look at this question. Most sensitive investigation for detection of pneumoperitoneum. Just apply the concept. Fluid is friend of ultrasound, air is enemy of ultrasound. So wherever in the body you want to detect air, ultrasound will not work, and therefore for pneumoperitoneum as well as pneumomediastinum as well as pneumothorax, the investigation of choice is going to be CT scan. That is the concept here. Yes. Now let us look at let us move on to obstruction, how to distinguish between small bowel obstruction and large bowel obstruction. This is also a very frequently asked question. Recently a question was asked. Let us see. When do you say, now in obstruction, bowel loops will be dilated, right? Bowel loops will be dilated. When do you say that a small bowel loop is dilated? You say that a small bowel loop is dilated when the diameter is more than 3 centimeters, but it is usually less than 5 centimeters. So it is usually more than 3 centimeters to less than 5 centimeters. Why? Because as it approaches 5, it becomes more than 5, it usually perforates. Large bowel is dilated when the diameter is usually more than 5 centimeters. This does not apply to the cecum though, because the cecum can normally be dilated up to 8 to 9 centimeters. So specifically for the cecum to be dilated, it is called as dilated when its diameter is more than 9 centimeter. Remember, this applies only for the cecum. Now, where is the large bowel located? See, large bowel is the cecum ascending, transverse, descending, right? So the large bowel is always located towards the periphery of the abdomen. Small bowel is located towards the central portion of the abdomen. Because the length of the small bowel is so long, right? When a small bowel loop gets obstructed, right, there are multiple loops with multiple and short air fluid levels. Whereas the length of the large bowel is relatively short, right? So therefore there are few loops. And what about the air fluid levels? Again, these are few but long air fluid levels because the diameter is larger. Now the most important way though to distinguish between small and large bowel is to look at the bowel wall markings. See how the bowel wall markings are strikingly different, and now next we are going to see them on an X-ray as well. See, small bowel wall folds look like this. Small bowel wall folds are complete transverse mucosal folds extending from one wall to the other, and what are they called as? They are called as volvulae conniventis. Volvulae conniventis. Whereas large bowel wall folds, if you see, they are incomplete transverse folds like this that do not extend completely across the lumen, and they are called as hostrations. So small bowel wall folds are called as volvulae conniventis. Large bowel wall folds, they are called as hostrations. That is how they are different. Now, if the small bowel loop is obstructed, nothing is going to pass distally, right? Distal to the site of obstruction, whatever is there in the large bowel is going to get emptied. So there will be no gas seen within the large bowel. But in large bowel obstruction, say suppose ascending, transverse, descending, the site of obstruction is splenic flexure, then what will happen? Proximal to it, the entire large bowel loop will be dilated. Distal to it, it will be collapsed. There is a sudden transition point at the site of obstruction. Yes, so these are the features that can be used to distinguish between small bowel and large bowel obstruction. The most important one of them is to look at the bowel wall markings. So let us look at bowel wall markings. See here. Look at these bowel loops. First tell me, where are these bowel loops located? Central or peripheral? Yes, they are located centrally. Now look at the bowel wall folds. Watch carefully. I have put up a zoomed inset there. Look at these bowel wall folds. Can you see these transverse complete mucosal folds? See here also you are able to see these transverse complete mucosal folds. See here also. So transverse complete mucosal folds extending from one wall to the other. What are they called as? These are called as volvulae conniventis. These are called volvulae conniventis, and this is the very classical feature of small bowel obstruction. Now let us compare it with large bowel obstruction. Now if you ask me location, right? If I say this is peripheral, it will create a little bit of confusion. But let me give you a clue. Don't get confused. Large bowel loop is peripheral except for the transverse colon. Because of the large transverse mesocolon, ideally, theoretically, a large bowel loop should be like this. Cecum, ascending, transverse, descending, sigmoid. So cecum, ascending, transverse colon, descending colon, sigmoid colon, right? But just imagine this transverse colon, this is slightly, hanging down because the transverse mesocolon is long. So instead of being horizontal like this, the transverse colon is usually like this, right? So it usually goes like this, right? So that is what is happening here. See, if you watch carefully, we start with the cecum ascending and the transverse is hanging down. Can you see this? So the transverse is actually hanging down, and then we go up to the splenic and we come down to the descending. Right? So this is what is happening here. Now if you look at the bowel wall folds here, watch carefully. See, can you see this? Transverse incomplete folds. See, transverse incomplete folds. See, multiple hostrations here. What are these called as? These are called hostrations. So what are these? These are transverse incomplete folds called as hostrations. And therefore, this imaging finding is suggestive of large bowel obstruction. Right? So this is what is large bowel obstruction. Now see, air fluid levels is another feature of small bowel obstruction, or bowel obstruction rather. We have seen how the difference in air fluid levels is. In small bowel obstruction there are multiple air fluid levels. Can you see here? Yes. And again, these are short width air fluid levels. This is a feature of small bowel obstruction that you see here. In large bowel obstruction there are few dilated loops but few long air fluid levels. Now, are air fluid levels always abnormal? The answer is no. In some cases, normally also air fluid levels can be seen. So normally also they can be seen. Now the air fluid levels are abnormal if they are more than 2 in number. Can you see multiple air fluid levels here? Yes. The width of those air fluid levels is more than 2.5 centimeters. So the width is more than 2.5 centimeters. They are abnormal. And if they are in the same bowel loop, then they must be at least more than 2 centimeters away. more than 2 in number, more than 2 centimeters away if they are in the same bowel loop, and width more than 2.5 centimeters. So this is when the air fluid levels are considered to be abnormal. Now see, when you see multiple air fluid levels in a same bowel loop and the height of those air fluid level goes on increasing, see here, 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 can you see this? So this is what is called as the step ladder appearance. So when you see multiple air fluid levels along the long axis of a bowel loop, and when they rise up like stairs, it is called step ladder appearance. Again, a feature of small bowel obstruction. Another sign of bowel obstruction is what is called as the small bowel feces sign. Now see what this is. Try to form a visual impression. This appearance that you see here, that is a hypodense appearance with multiple jet black dots within it, that is air specks, is actually how the fecal matter appears. Is how the fecal matter appears on CT. And this appearance, therefore, if seen inside a colon, is considered to be normal. But here we are able to see this fecal matter where? Not in the colon, but in the central small bowel loops. So when you see the fecal content within the small bowel loops, it is abnormal. It means that there is a prolonged stasis of the contents, and as a result, this fecal matter like content is now seen within the small bowel loops. This is called the small bowel feces sign, and therefore this is also a sign of intestinal obstruction. Yes. Another sign of intestinal obstruction is, now here if you watch this CT image carefully, can you see this fecal matter? So this is fecal matter within a small bowel. So this is small bowel feces sign. But see, in its non-dependent part, can you see these air specks? Now if there are multiple air specks like this, just imagine this looks like a string of beads, and therefore this is given the name of a string of bead sign. These are nothing but air specks that rise up and they are collected as beads on the non-dependent part of the bowel loop in between those folds. Yes. Now the most reliable CT criterion of obstruction on a CT scan. So on a CT scan, the most reliable finding is called as transition point. What is the transition point? This is the site of obstruction, exactly. And therefore there is a transition. What will happen? Proximal to this site, everything will be dilated. At this site, there will be a sudden narrowing, and distal to it, the bowel will be collapsed. And the distal to it, the bowel will be collapsed. So this site of obstruction is called transition point. On a CT, we try and always identify the transition point because that tells us something about the cause. If you don't identify anything structurally abnormal at that site, we say that probably there is an adhesion there which causes that particular obstruction. So if you see here in this particular CT image, right, you see that all these bowel loops are dilated and there is one dilated loop here. See, there is a sudden narrowing of the bowel, and distal to it, this bowel loop is collapsed. So this is the transition point. Once you identify the transition point, it gives us a clue as to what could be the underlying cause of obstruction, right? And therefore, this is considered to be the most reliable CT finding in intestinal obstruction. Now let us consider pneumobilia. Actually, I could have considered it in hepatobiliary discussion, but I am discussing it here because it is related to a condition that causes intestinal obstruction. So what is pneumobilia? As the name suggests, pneumobilia is air within the biliary tree. How will it look like? Look here. Look at this particular radiograph. On this radiograph, this is how the liver is going to be. Inside the liver, can you see this black line? Where is it located? It is located in the central portion, close to the porta hepatis. So air has entered into the biliary tree. The most common cause of pneumobilia is recent instrumentation of the biliary tree. Say an ERCP has been done, a stent has been put, or say anastomosis has been done, a biliary enteric anastomosis has been done. So air enters into the biliary tree. But remember, there is a specific cause of pneumobilia, and that is related to intestinal obstruction in a way. That condition is called as gallstone ileus or cholecystoduodenal fistula. Sometimes, when there is a cal within the gallbladder or in the biliary tree, it can pass from the biliary tree either from the gallbladder directly to the duodenum by formation of a fistula, or through the biliary tree. When this calculus passes into the bowel, what happens? When this calculus passes into the bowel, it gets impacted at the most narrow portion of the bowel, and that is the terminal ileum. So the calculus is impacted where? It is impacted at terminal ileum. So it creates intestinal obstruction that is called gallstone ileus. It is characterized by a classic clinical triad. What is that triad? That triad is a triad of pneumobilia plus presence of small bowel obstruction, right? Pneumobilia, presence of small bowel obstruction, and there is a density which corresponds to a calculus seen in the right iliac fossa. So this is what is called as the Rigler's triad. What is this called as? This is called as the Rigler's triad of gallstone ileus. So Rigler's triad is pneumobilia, small bowel obstruction, and the cal is impacted. So what is the site of obstruction in gallstone ileus? It is terminal ileum. It is because of the gallstone passing into the lumen of the bowel. Now, based on all this discussion that we have had about the appearances of radiographs, see, this was a question which was asked. On an abdomen radiograph, air in the rectum is seen in. Now, air in the rectum is seen normally also. We have discussed it when we discussed the small bowel feces sign. So, normal person it is seen. Large bowel obstruction, if there is anywhere the site of obstruction is a sigmoid colon, nothing will pass distally. So, air will not be seen in the rectum. Small bowel obstruction we have already discussed. Nothing is going to pass distally. So whatever is there in the large bowel will get emptied eventually. So there will not be, it will not be seen. In paralytic ileus, yes, in paralytic ileus there is no obstruction, right? It is just the, the motility of the bowel is affected. So air in the rectum will be seen. Gallstone ileus, what is gallstone ileus? Gallstone ileus we have seen is nothing but small bowel obstruction. What is happening is that the gallstone which has passed into the bowel gets impacted where? It gets impacted most commonly at the terminal ileum, right? Therefore, nothing will pass distally, so there will be no air in the rectum. And therefore, the answer to this question, yes, is going to be a normal person and a paralytic ileus. Now, there are various spotters that I want you to know, right, in the GI tract imaging, and we are going to discuss them in a clinical scenario based pattern. So look at this scenario here. A neonate presents at birth with bilious vomiting, which means there's something congenitally wrong, and bilious vomiting means that if there's obstruction involving the bowel, it is distal to the site of the ampulla of the duodenum, that is distal to D2 mid part. So what do you see on this particular radiograph? On this image that you see here, do you see two bubbles? This is the first bubble. This is the second bubble. The first bubble is what? First bubble is the stomach. Second bubble is what? It is the proximal duodenum. And there is an obstruction here in the second part of the duodenum. So everything proximal to it is dilated. Even the bile which is coming into the proximal duodenum is getting vomited out. So therefore the child has bilious vomiting. So this is an atretic segment involving the second portion of the duodenum. So what is this? This is the double bubble sign which is seen in duodenal atresia. So what are we seeing here on this image is nothing but the double bubble appearance which is seen in duodenal atresia. A single bubble appearance has conventionally been described in pyloric stenosis because the stomach is dilated only. A double bubble appearance is duodenal atresia. A triple bubble appearance has been described in jejunal atresia. Yes, so this is about duodenal atresia. Now see, there's a specific history clincher, right, which is associated with this particular imaging finding. What is that? So it is an elderly female, a known case of psychiatric illness, presence with massive gaseous distension of abdomen, and absolute constipation. Now, what are the imaging findings which are seen in a case of sigmoid volvulus, right? So in sigmoid volvulus, we have already seen here that there is a massive gaseous distension of bowel loops. It has lost its haustrations. Now, this shape of the bowel loop that it takes, this is what is called as the coffee bean sign. Coffee bean sign. This has also been called as the bent tire tube sign, also called as inner tire tube sign or omega sign. Then there are various overlap signs. Now usually remember the peak or the apex of the loop is usually under the left dome of diaphragm. Now because the loop is so massively distended, it overlaps various structures. So there is a liver overlap sign, left flank overlap sign. So there is a liver overlap sign, left flank overlap sign, pelvis overlap sign. All these overlap signs are seen. Now see, when the loop gets dilated like this, suppose this is the loop, right, and the central walls are approximated like this. So this is the dilated loop like this. There are three lines which are seen. So these are the two outer walls and these are two inner walls which are approximated. These three lines, as they converge towards the site of twist here, this is also given a name. This is called as the Freeman Dahal sign. So three lines, prominent lines that point towards the site of twist. So here the Freeman Dahl sign is actually not very well seen, but it would be this line here. So this is the outer bowel wall. This is the outer bowel wall of this loop. So all these three lines would point towards the site of twist, which is somewhere over here. So that is what is called as the Freeman Dahl sign. Now the first step in the management of sigmoid volvulus is to try and pass a flattest tube. If we can do that and decompress this particular loop, surgery can be avoided. But otherwise a colostomy would be required, a surgical intervention would be required. This is something that we'll discuss in surgery. Now see here, this is a newborn who presents with respiratory distress. A very typical finding, right? Do you see the left dome of diaphragm? The left dome of diaphragm is not seen. Instead, you see all these bowel loops extending into the left thoracic cavity, causing a mediastinal shift towards the opposite side. So this is where the diaphragm does not develop, or there is a defect in the diaphragm. So what is this? This is congenital diaphragmatic hernia. The most important prognostic predictor in cases of congenital diaphragmatic hernia is the associated pulmonary hypoplasia. The degree of pulmonary hypoplasia is the most important determinant of the prognosis or the outcome. Mostly diaphragmatic hernias are the Bokdalek type. So Bokdalek type, which is commonly on the left side, as you can see here. Okay, so this is a congenital diaphragmatic hernia. Now look at this particular patient. This is an elderly male who presents with dysphagia more for solids as compared to liquids and weight loss. So elderly male with weight loss and dysphagia more for solids points towards a possibility of malignancy. And remember, dysphagia for liquids more than solids is usually an indicator towards achalasia, but for solids more than liquids is usually an indicator towards an esophageal malignancy. If you see here, where is the esophagus located? Esophagus is located, behind the heart and the great vessel. So if you see, this is the trachea here, and this is a big esophageal soft tissue located right behind the trachea. See, this is the heart here. Just behind the heart, this is at the infracarinal level. You see a big soft tissue there. So as if there is a tumor which is showing a little bit of enhancement along the esophageal wall. So this is what's suggestive of esophageal cancer, right? What is the staging modality of choice for esophageal cancer? The staging modality of choice for esophageal cancer is to do a PET CT, because that will show us whether there is distant involvement or metastasis which are there. Yes. Now see here, this is a patient who actually presented with repeated episodes of diarrhea. So a 38-year-old male presents with recurrent diarrhea and weight loss. Why? Because if you see, the bowel loops are appearing inflamed, especially if you watch carefully along the mesentery. Can you see these prominent blood vessels? So there is a hypervascularity in the mesentery. These blood vessels are traveling towards the adjacent bowel loops. This appearance looks like that of a comb. So this is what is called as the comb sign of Crohn's disease. So this is called as the comb sign. Why is there this comb sign which is seen? This comb sign is seen because of there is hypervascularity along the mesentery, right, with linear vessels which are seen going towards the bowel loops. This is a feature of bowel inflammation which is seen in Crohn's disease. Now, Crohn's disease is also called as regional enteritis. Crohn's disease is regional enteritis in which the most common site of involvement in Crohn's disease, remember, is the terminal ileum. Is the terminal ileum, and this basically gives rise to discrete ulcers, skip lesions. Barium meal follow through was used in the olden days, which used to show various appearances. One of them is called as the cobblestone appearance. Cobblestone appearance of bowel mucosa. Right, so cobblestone appearance of bowel mucosa is another named finding which is seen in Crohn's disease. It can give rise to narrowing or strictures along the bowel. This is what is called as the string sign of Cantor. So this is called as the string sign of Cantor. The best investigation considered to be for a diagnosis of Crohn's disease is usually a contrast enhanced CT scan, or CECT is considered to be the best investigation. So here we are able to see the Coombs sign. There are various signs which have been described on CT as well. So on CT, signs have been described which are called as the fat halo sign, that is a halo of fat, inflamed fat along the bowel loops because of the bowel inflammation. There is creeping fat sign. Creeping fat sign which has also been described. This is the fibrofatty proliferation of the mesentery around the inflamed bowel loop. So CT scan, on CT scan, Coombs sign, fat halo sign, creeping fat sign. Whereas on conventional studies, what was described as cobblestone appearance of mucosa, string sign of Cantor. These are the features of Crohn's disease. Now see, this patient again, see, middle-aged male, presents with recurrent diarrhea, weight loss, but now instead of the small bowel loops, large bowel loop is predominantly involved. What do you see? Look at this large bowel. Can you see it has lost all its hostrations? It has completely lost all its hostrations. So it looks like a lead pipe. So this is what is called as the lead pipe colon in ulcerative colitis. Ulcerative colitis gives rise to backwash ileitis, so the inflammation can extend into the ileum as well. It predominantly starts with the involvement of the rectum, and from there is a proximal extension of the inflammatory process. That is how ulcerative colitis mainly occurs. In the early stages, on double contrast barium enema, appearances have been described which has been called as, the earliest finding is usually the granular appearance of mucosa. Granular appearance of mucosa which is seen on barium enema. There could be various ulcers. These are called as buttonhole ulcers or collar stud ulcers. There are pseudo polyp-like appearance which is created because of the ulceration of the mucosa. So pseudo polyp-like appearance is created. Pseudo polyp-like appearance is created. Now, one important complication of ulcerative colitis is called toxic megacolon, in which there is progressive dilatation of the transverse colon. Usually the diameter exceeds 6 to 7 centimeters. It usually requires surgical treatment. Okay, so these are what are important features you need to know as far as ulcerative colitis is concerned. Now, this was a patient who presented elderly male, acute pain in abdomen and blood in stools. So elderly male presents with pain, acute onset, and blood in stools usually points towards could be bowel ischemia, and this gave rise to ischemic colitis. Can you see all these impressions because of the bowel wall edema? See all these thumb-like impressions on the bowel lumen. This sign is called as thumb printing, which is seen in ischemic colitis. So this is a sign which is called as thumb printing, which is seen in ischemic colitis. Now, usually causing ischemia, though this is involving the colon here. If you look at ischemic bowel disease, right, the bowel wall ischemia, the most common vessel usually involved is superior mesenteric artery. Right, so ischemic bowel involvement, the most common vessel usually involved is superior mesenteric artery. The investigation of choice is usually CT angiography, and the gold standard is going to be invasive catheter angiography. is going to be invasive catheter angiography, right? Thumb printing is because of mucosal edema, that is a impression on the bowel lumen. Now sometimes there can be shock bowel, which is actually nothing but complete absence of enhancement of the bowel wall on contrast injection. If there is air within the bowel wall lumen, then that is called as pneumatosis intestinalis. That can give rise to pneumoperitoneum as well if they perforate. So this is about the ischemic bowel pathologies. Now acute appendicitis can be a history clincher. How is it a history clincher? Now it can typically present with severe RIF pain, right? Could be associated with vomiting, which is basically induced because of pain. There could be mild fever or signs of infection, inflammation, and there is typically tenderness in the right iliac fossa at the Morrison's, right iliac fossa at the McBurney's point, beg your pardon. So there is tenderness at the McBurney's point within the RIF. Now, what is the investigation of choice for the diagnosis of acute appendicitis if a patient presents with this history and it is a child, right? McBurney's point, tenderness, vomiting, RIF pain. Patient is a child. What investigation will you do? Investigation of choice for acute appendicitis in children, remember, is ultrasound. Whereas for adults, the investigation of choice is contrast enhanced CT. CT is much better, but in childhood CT is usually avoided because of the high radiation exposure. Therefore, the investigation of choice is ultrasound. Now, how does the inflamed appendix basically appear? So a gradual graded compression technique is used. Appendix, remember, is a blind-ended tubular structure. So we see a blind-ended tubular structure on ultrasound in RIF, right? And this particular structure usually has a diameter of more than 7 mm. So the diameter of the appendix is usually more than 7 to 8 mm. The appendiceal wall may be edematous, adjacent mesentery may appear echogenic. There could be a calculus or a calcified structure within it, which is then called as an appendicolith. The presence of an appendicolith increases the chances of perforation of the appendix, and hence the complication rate is increased. In adults, CT scan is considered to be the investigation of choice. So you see that the appendix is, prominent here. The diameter is more than 7 to 8 mm. These lines that you see around the appendix are features of inflammation. Periappendiceal fat stranding is seen. There are various signs that have been described in acute appendicitis. These signs are called as the cecal bar sign, arrowhead sign. So cecal bar sign is nothing but a layer of edematous cecal base which lies between the appendix and the cecum. The contrast material, if the patient is given contrast material to drink, the cecal, contrast material actually creates an arrowhead which points towards the appendix. That is sometimes a clue. That is what is called as the arrowhead sign. Okay. Now lymphoma in the abdomen basically gives rise to multiple enlarged confluent lymph nodal masses. Now because these lymph nodal masses completely encase the abdominal blood vessels, see here the aorta is appearing completely encased or embedded within the lymph nodal mass around it. So this is what is called as the vessel embedded sign. Sometimes the mesenteric vessels which are passing across, they become completely embedded, right, within the lymph nodal mass, and that is what is called as a sandwich sign or a hamburger sign. So vessel embedded sign, sandwich or hamburger sign, these are features of abdominal lymphoma. They present with multiple confluent lymph nodal masses which show very low level of enhancement on post-contrast studies. Now we come to what is FAST. How do we clinically evaluate a patient of abdominal trauma? Whenever a patient comes with a history of abdominal trauma, the first investigation which is done for assessment of these patients is usually FAST. What is FAST? FAST stands for Focused Assessment with Sonography in a case of trauma, that is abdominal trauma. What is the concept of FAST? The concept of FAST is the same concept that we have studied about ultrasound, and that is fluid is friend of ultrasound. What is the purpose of doing FAST? The purpose of doing FAST is to detect intraperitoneal free fluid. If there is free fluid within the peritoneal cavity in an abdominal trauma patient, it means that that fluid is not just clear fluid, but that fluid is going to be blood. From where is that blood coming? This blood is coming probably from a solid organ contusion like a liver contusion or laceration, or a splenic contusion or a laceration. So the first step in the management of abdominal trauma patient is to do a fast. If you see free fluid, then it is called as fast positive. So fast positive, and when we see free fluid, it means that that free fluid is very highly likely to be blood. Then what do you do? Then what we do actually depends upon the patient's hemodynamic state. So if you see fluid positive, it means that that is hemoperitoneum due to a solid organ injury. If the patient is hemodynamically stable, then you can do the investigation of choice for solid organ injury, and that is contrast enhanced CT. Because the patient is stable, you have time to do a CT. But if the patient is hemodynamically unstable, you do not have time to do a CT, because the patient can deteriorate, collapse, die any moment because of hypotension, because of the torrential bleeding which is happening in the peritoneal cavity. And therefore in these patients, usually an emergency exploratory laparotomy is usually done. So this is the protocol for management of abdominal trauma patients. Remember, questions have been asked at multiple times. A question was asked recently here. Abdominal trauma patient, what will you do first? A question can be asked here. 2 years back it was asked here. So fast was positive, then what do you do? Right? Suppose hemodynamically stable, what do you do? Hemodynamically unstable, what do you do? Multiple points along this particular protocol of clinical management questions can be asked. Now let us see what is the standardized fast protocol. Just try to form a visual impression of this image. Draw a vertical rhomboid over the abdomen, and at the 4 corners of the rhomboid you keep the probe. This is the fast protocol. So what are the views involved in this fast protocol? A subxiphoid view, a longitudinal right upper quadrant view, a longitudinal left upper quadrant view, and a suprapubic view. Now among these views, what is the first view which is usually obtained? First view obtained is a subxiphoid view. Yes, where we can see the pericardial cavity, we can see the left lobe of the liver, right? In the right upper quadrant is the next view which is obtained. In these views, what is the best view or most sensitive view for detection of hemoperitoneum, that is blood within the peritoneal cavity? It is, remember, this right upper quadrant view. Why? Because it helps us see the Morrison's pouch, which is considered to be one of the most deepest and dependent most part of the peritoneal cavity in supine position. So the overall best or most sensitive view is the right upper quadrant view. The first view obtained is usually the subxiphoid view. Yes, now there's something which is called as E-fast. What does E in E-fast stand for? E stands for extended fast. So what is this extended fast? When you extend the evaluation of fast by involving the thorax. So thoracic views are obtained, right? There are, the thorax is assessed at usually 2 sites. One, it is assessed in the upper portions, in the non-dependent part, to rule out pneumothorax. 2, it is assessed in the lower dependent part to rule out hemothorax. So total 6 views are then obtained. 2 thoracic views are added to it. Now there's something which is called as fast we are discussing. So there's something which is called as BOAST that I want you to know. What is BOAST? BOAST stands for bedside organ assessment. It stands for bedside organ assessment with sonography in trauma. So this is what is called as BOAST, which is also used in trauma patients. So what is extended fast? When you extend the involvement to look for hemothorax and pneumothorax. So thoracic assessment is also done. Now USG or E-fast, look at this question, is least useful in the assessment of what? So see, can it be used for assessment of pneumothorax? Yes, we have just seen it. It can be used for assessment of pneumothorax if we do an extended fast. Can it be used for assessment of pericardial effusion? Yes. When we start with the subxiphoid view, we can see the heart and the pericardial cavity. If there is fluid, we will be able to detect it. Now, renal injury, kidneys are retroperitoneal structures as well as retroperitoneal hematoma, right? It is very difficult to detect. USG is not a good modality for retroperitoneum, right? But can we see when we do the right upper quadrant, left upper quadrant, right? Can we see the kidneys? Yes. So if I have to choose between these two, ideally ultrasound is not good for both of them. But when I do the right and left upper quadrant views, I actually see the kidneys, and therefore a large renal laceration or a prominent renal contusion will be seen. And therefore, if I have to choose between them, I'll say that USG or EFAST is least useful for detection of retroperitoneal hematomas. Yes, it is not a good modality for assessment of retroperitoneal hematomas. Yes. Now, what clinical insights have we got from this particular discussion? This is important. What is the best X-ray or best radiograph for detection of pneumoperitoneum? We discussed it with the use of graphics also, right? That is an erect chest X-ray is considered to be the best X-ray for minimal pneumoperitoneum. But what is the overall investigation of choice? Anywhere in the body you want to detect minimal quantities of air, what will you do? The best investigation will be CT scan for pneumoperitoneum. Then we come to certain intestinal obstruction specifics. What is the first investigation that is done? First investigation is usually abdomen erect plus supine radiograph or X-ray is the first investigation which is usually done. What is the investigation of choice for obstruction in children? Remember, CT is good, but it usually is avoided in children. So the investigation of choice in children is ultrasound. Whereas the investigation of choice in adults becomes contrast enhanced CT, because it not only shows us that there is obstruction or not, it also tells us what could be the underlying cause for that particular obstruction. The most common cause of obstruction which is found is adhesions, right? So adhesions is the most common cause for intestinal obstruction. Yes. Now, intestinal obstruction specifics, let us have a look. See, a child presents with vomiting. Now, age of the child and what kind of vomiting it is, the diagnosis will be different. So, if it is a newborn at birth and who has bilious vomiting or presents at 6 to 12 weeks with non-bilious vomiting, diagnosis will be different. If it is a newborn at birth with bilious vomiting, I said is a congenital atretic segment of the bowel distal to mid D2 part. So this suggests duodenal atresia, right? Whereas, right, if it presents late, not immediately at birth, right, after around 6 to 12 weeks and non-bilious vomiting, which means that the obstruction is proximal to the second part of duodenum, this suggests pyloric stenosis. Yes, will you be able to distinguish between them? Even without an image, just by looking at the clinical history, it is actually possible to distinguish between them. Of course, they will have different imaging patterns. Duodenal atresia will show you double bubble sign. Pyloric stenosis, we have seen USG is the investigation of choice. We have also seen various signs on a barium mean study. Yes. Now we come to this quiz. Look at this: free air under the domes of diaphragm. Patient presents with severe abdominal pain. Erect radiograph is done. Right. What should be the management? Now in this case, the management is going to be an emergency exploratory laparotomy, because there is perforation which has been documented. Right. There is pneumoperitoneum. The cause is perforation. So we have to identify the site of perforation and treat it, close it, do a resection anastomosis. Right. So this is what is the management in this particular case. Right. So laparotomy is going to be the management. Now, what is this bowel loop? This patient presents with abdominal pain and distension. X-ray is taken, shows dilated bowel loops. Look at this bowel loop. Look at the bowel wall markings. Can you see? Can you see that there are complete transverse mucosal folds which are there along this bowel loop? And where is this bowel loop located? It is located in the upper left abdomen. So this is very likely to be a jejunal loop. Now bowel loops, small bowel loops, if they are seen in the central lower abdomen and they don't show these prominent volvulae conniventes, then these are usually the ileal bowel loops, because ileal bowel loops usually have a featureless appearance, right? Whereas the feathery appearance or prominent volvulae conniventes is a feature of jejunal bowel loops. Their location is also different. Jejunal bowel loops are in the upper left abdomen. Ileal bowel loops are usually in the lower and central abdominal cavity. Yes, so this is jejunal bowel loops. A patient following a skid resulting from a road traffic accident comes to emergency. GCS is good, pupil is reactive, tenderness, bruising over the left lower chest. Query: rib fractures, and as a result of rib fractures, there could be some splenic injury. And see, patient has petechiae, patient has tenderness in the left hypochondriac region, BP is low. So abdominal trauma with query rib fracture, query splenic injury, what do you do first? We studied the protocol. First step in the management of abdominal trauma is FAST. If FAST is positive, this patient is what? This patient is hypotension. If FAST is positive, the next step would be an emergency laparotomy because the patient is already in hypotension. So this is the protocol for management of abdominal trauma. We have discussed this.